Anybody have any questions or anything before we get started? Cool. Beckley's cool.
Cool.
No. We got the frowny face again.
I'm going to mute us.
You're going to mute yourselves? Okay. I don't know if this is going to, I don't know why this does this. We have blank white slides. Let's see. Hang on, or my screen's not wanting to share the right way. I'm going to stop screen sharing for a second and reshare it. We're going to talk about that. Oh, the joys of technology, right? Yeah, so it's not a handout. I'll talk about those too. Remind me at the end, and I'll give you guys so you guys can start looking at those. Okay. Now, if Beckley and it's recording. All right, cool. So today we're going to go over chapter 10 is about disruptive impulsive control and conduct disorders. Without me starting the lecture, what are some things that come to mind or disorders that fall into this group that, you know, you might have had in your head before from your pre-reading, or what are some of these disorders? ODD, yeah. That's a big one. That's probably the most common one we're going to talk about today. What are some other ones? Explosive. Yeah, okay. Let's what is it? Yeah, that's another one. Let's talk about, I'm going to break these down a little bit. Some of these you're going to find are very different or very similar in each other. They're harder to diagnose, harder to differentiate between each other. I'm going to try to give you some key characteristics that'll help you do it, as well as we're going to play on for the next exam. I've come up with a exam review game that we're going to do, and it's got a lot of good breakdowns too on how to differentiate between these disorders. Okay. All right, so oppositional defiant disorder, ODD. In order to gain this diagnosis, they must display a pattern of defiance lasting at least 6 months. Okay, there's all types of different symptoms, but they must at least have 4 that go underneath the category of angry or irritable mood, argumentative and defiant, and vindictiveness. So when you're dealing with somebody who has ODD, do you think of someone who is a child or an adult? Child, right. So individuals that are older than 5 years old should have these symptoms for at least 6 months and occur at least 1 time a week. And these interactions also must be with someone who is not a sibling. Okay, so that they can't just have, these interactions, these behaviors with a sibling only. It has to be with someone other than a sibling. And then individuals that are under the age of 5, they should last for at least 5 months and occur on most days, not just once a week, but most days in order to gain this diagnosis. So it changes a little bit in age on how frequent they might have an outburst or an episode, right? What are some other things you think that can affect this diagnosis or gaining this diagnosis? Or what are some other instances that this might be something else, not ODD? Not necessarily. Like, what are some other things that can affect like these kind of behaviors, the angry, irritable mood, stuff like that? What are some other things that could make them have this kind of a reaction or outburst other than having a diagnosis of ODD? Abuse could be something. Okay. What else? So like environmental factors. Okay. What else? Okay. That's not, I hadn't thought of that one, but I think so. Yeah. They don't.
Like with celiac, they can't have gluten.
Interesting. I didn't know that. That's interesting. What about like gender differences or cultural differences or stuff like that? You really have to take in that holistic perspective with, trying to diagnose ODD. This is another one you guys can talk to Dr. O'Keefe about a lot for diagnosing. He has seen it quite a bit. So he can talk about that a lot too when he comes in, and I think it's next month. All right. The next one is intermittent explosive disorder. They must be at least 6 years of age and is defined as recurrent behavioral outbursts that represent a failure to control aggressive impulses. This is where you're going to see things like verbal aggression or physical aggression, and this can be towards property, this can be toward animals or people. What would be an example of verbal aggression? Cursing, temper tantrums, stuff like that. Now, that doesn't necessarily mean that, just because someone has a temper tantrum doesn't mean they're thrown into intermittent explosive disorder, right? You have to be able to differentiate between those two. It must cause the individual stress or impair occupational functioning and have financial or legal consequences. As far as the occurrence, it must occur at least twice weekly for a period of 3 months, or have at least 3 outbursts that involve damage to property or a physical assault, a physical injury happening of something, an animal or a person. And those are normally within like a 12-month period. Okay. One thing to remember with this is their reaction to these situations is completely out of proportion. It's just way over the top. This could be something like, the dog ran and brushed up against them and they kind of lost their balance for a second, and then they just absolutely lose it and, beat the dog. This is completely out of proportion reaction to something. Okay. Any questions? We good with that one? Okay. Conduct disorder. This is behavior that violates the rights of others and social norms. There's lots of different symptoms, but they fall into different categories, these 4 categories. I'll go slow so you guys can write these down if you want. They're in your book too. The first one is aggression towards people and animals. The second one is destruction of property. The third one is deceitfulness or theft. Okay. The fourth one is serious violations of rules. This is like being truant from school, even like at an early age. So their behavior also must cause significant impairment into social, academic, or occupational function. And then lastly, if the patient is over 18 years old, they have to not meet the criteria for antisocial personality disorder, which we're going to talk about in just a second. They can't have both. They can't meet the criteria for antisocial personality disorder and have a conduct disorder diagnosis. Okay? All right. Well, maybe. Let's skip one. There we go. Antisocial personality disorder. This falls under a very broad category of personality disorders that we're going to talk about later too. This is only given to individuals 18 years or older. There's a history of symptoms of conduct disorder before the age of 15. Okay? This is characterized by complete disregard for other people or the rights of others. They have no empathy toward other people. And they must display at least 3 or more of the 7 specified behaviors. And I'm going to list those off for you too. At least 3 out of the 7. All right. The first one is failure to conform to social norms. Deceitfulness. Irritability and aggressiveness. Yes. Reckless disregard for the safety of others. Lack of remorse. And failure to conform to lawful behaviors. Okay. Any questions? We good? All right, we'll keep moving. Shouldn't be. 1, 2.
You said irritability and aggressiveness are one, right?
No, you're right. I didn't see the comma there. Irritability and aggressiveness are 2 separate ones. Sorry. Some of them. Failure to conform to social norms. Okay. All right. So pyromania. This is the impulse to purposefully and deliberately set fires on more than one occasion. This one's kind of, even just strange to think about that somebody, so they have this sense of tension or stress before setting a fire, and then after setting a fire, they get this sense of relief. So it's a stress reliever. They have this overwhelming fascination with fire and burning. Just because somebody sets fires does not always mean that they, will later get a diagnosis of pyromania. It depends on the situation. Are they doing it for that relief? Is that what gives them that relief, that stress reliever? That's when it turns into pyromania. It's associated with other impulse behaviors like alcohol and marijuana use, as well as, it's associated with a history of trauma. Okay. All right. Kleptomania. This is associated with tension or anxiety that is relieved by stealing something. One thing to remember here, that the stolen objects are not for personal use. They don't really gain. It's not I need it, so I'm taking it kind of thing. They just get a relief from stealing something. It's not done out of anger. It's not done out of vengeance. And it's not from a hallucination or delusion that they feel like they need to. It's just they get a relief from stealing something, and it's not for gain. This is a really, pretty rare disorder too. Cool. All right. So now that we've covered all those different disorders, what are the causes of these disorders? Again, there is nothing that we're saying this is the cause of, what causes pyromania. I mean, we don't know what is the exact cause. It's in fact very, very difficult to try to even pinpoint and diagnose. A lot of the times these diagnoses are comorbid with other things like ADHD, even like fetal alcohol syndrome. There's different things that are comorbid with these disorders. It's not often that they have just one. Some different things that they've done studies about that can show that could lead to these diagnoses is corporal punishment, very harsh discipline in both boys and girls can be related to getting this diagnosis later in life. Any of these diagnoses, early or later, some environmental factors, bad classroom atmospheres, traumas, maltreatment, neglect, all this bad stuff, right? What I want you to remember is that these are disorders that are not caused by bad parenting. It is not caused by bad parenting. Okay? They're not. Now, what I just told you is that environmental factors, right? Like trauma and stuff like that I'm not talking about clearly if you have, beaten or neglected your child, that is bad parenting. I'm talking like bad parenting styles. Like neglecting your child isn't a parenting style. It's traumatic, right? It's not like put it this way. You don't have a child that has ODD because the mom is a bad parent in the sense of they don't know what they're doing kind of thing. If they're abusive, it very well could be because it's a traumatic event. Does that make more sense? Yeah. Okay. And then there's neurological factors as well. A low responsiveness in the amygdala. Does anybody remember from anatomy class what the amygdala does in your brain? Kind of aggression, emotion regulation is the amygdala. A lot to do with emotion. And then the prefrontal cortex, which is... You got me. I don't know. I didn't bring my neuroscience hat today. But just speaking in across disruptive and conduct disorders, the amygdala and prefrontal cortex are a little bit different, the connections in between the two. Prefrontal cortex is the planning, executive functions, stuff like that. Not being able to reason, wow, maybe setting this fire for stress relief is not a good idea. Okay. All right. So prevalence and gender. Conduct disorder often occurs with, or disorders occur with ADHD. It's very high among prison populations and with substance abuse. Twice as many males as females, except with ODD where it's about equal. Why do you think that is? That twice as many males as females? Let's have a little discussion here.
Repeat the question again.
Why do you think there's twice as many males as females that are diagnosed with conduct disorders? Except ODD, that's about 50-50.
Well, the females tend to be less aggressive.
Okay, a nurturing nature. Okay, so that's the whole nature versus nurture discussion, right? The big question of what makes a person a person. Interesting. Okay, what do you think, Isaiah?
Well, if we're going to corporal punishment or trauma and neglect,
Mhm.
I would feel like if you're parenting, usually a son could be seen as maybe being able to take more abuse. So you
Okay.
might use them a little more.
That's an interesting point for sure. Okay, what else? Why do you think ODD is about equal? I remember you guys were talking about ODD way before this lecture. So what are, in your experience, the whole 50-50?
I feel like they give that out so much.
They give it out so much?
Yeah, it's just so common that if there's any issues, it's like that kid has it.
Yeah, it's like boom. It's kind of like how we talked about with ADHD and stuff too, right? Like it's an overly diagnosed thing that necessarily, like, I think I've shown you guys pretty good now that it takes a lot of criteria, but they're hard to differentiate between. Okay, so I don't think it's that difficult to say maybe that umbrella term of disruptive and conduct disorders, but saying like this is ODD, this is, I think it's way more difficult. So. Let's talk about the course. Disruptive behavior disorders diagnosed in children and adolescents are present within the adult population, meaning that they don't stop, they carry over. Okay. When adults go from, conduct disorders or disruptive these things, normally they are diagnosed later, not always, but they will go for the antisocial personality disorder diagnosis is what they'll fall into. Now, let me back up. I didn't mean to say most. Most don't actually go on to develop that. It is something that can be, more well tolerated through therapies and stuff like that. But, once somebody is diagnosed with something, it tends to be a lifelong deal. Okay. Might not present itself as much, but, it's there. Let's see. For a lot of people, disruptive behavior is limited actually to the childhood and adolescence part of it, meaning that as they get older, you're not going to see the more physical outbursts and stuff like that. I mean, it still could be there, but what are some things you think occupational therapy might work on with somebody? Let's say with ODD. Triggers. That's a big one. We're going to talk about that in a second. Finding out what the triggers are. Okay, so let's just assume now you have identified what the trigger is. What are some interventions you might do with somebody? Awesome. That's perfect. Anger management techniques. In what way? You guys have experience with this, right? You've seen it, and it's.
I mean, I had a boy. He every time I saw him, he told me it didn't work. But like his occupation, I told him to squeeze his fingers.
Yeah.
He's mad.
Yeah. What?
Like counting, I guess.
Counting. Okay. So trying to take their redirecting, more or less, taking their attention off of whatever the trigger was and trying to redirect it to something else, like counting, breathing, stuff like that. Good. As far as the impact on occupational performance, just overall, they're going to have, difficulty when their sense of control is threatened, not being able to have or to control these outbursts, difficulty with following protocols in work or school, and difficulty taking directions, especially from authority. ADLs and IADLs, probably little to no attention to self-care, planning, or executive functioning. This, I need to wake up, brush my teeth, take a shower, do laundry, self-care tasks. Generally, they have weird or erratic sleep habits that are abnormal, which makes it worse because even us, if we wake up and we're tired and we're irritable throughout the day, we're probably, when the guy cuts us off in traffic, we're probably not going to respond the right way, right? Telling us number one. A lot of times they have substance abuse or even caffeine dependency. I'm also caffeine dependent, but I don't have one of these, I promise. Don't give me that look, Jennifer. And then so as far as the influence, so as a child, corporal punishment, emotional abuse can influence, their way to do ADLs. As an adult, the influence is going to be they're going to struggle with focus, unable to prioritize, probably be very, frivolous with spending, planning, all that stuff. Academics and employment. Unpredictable situations and expectations may be triggers. So looking for a work environment where they don't have this unexpected, unscheduled time stuff where, things just pop out, that might be a big stressor or a trigger. They're probably going to require ongoing support from management or from coworkers or from their therapist or whoever, and self-management strategies. Going back to the idea where you was talking about, Jennifer, with triggers. So if you are working with somebody that's, you're looking for a job placement, what might be a good example of something that they would avoid? Let's say this unpredictable situations or something where they have to kind of fly off the seat of their, what's the word? Like they have to, fly off the seat, thank you, off the seat of their pants, just kind of coming up with something and working on their feet. What might be a job where you can avoid situations like that? Okay, cutting grass. Interesting. Tell me why.
I'm thinking of like VRS job. Like, I definitely like having a manager that's a little more laid back
Mm-hmm.
and not right on my back all the time.
Okay.
They don't have to do well with directions.
Okay. So, but at the same time, if, unpredictable situations is their trigger, wouldn't you want to have a manager that was more structured and this is the way it is and that doesn't deviate? This is the way it is. So it's kind of hard to find that balance, right? In between, not being able to take orders and struggling with authority and at the exact same time, keeping it structured. It's kind of hard, right?
So it would be like telling them what to do. They have the freedom to make their own option.
Right,
Yeah.
right.
Yeah, like, this is how it goes here.
Yeah.
All the rules. And I won't be on your back all the time, maybe.
Right. Or even like, I think what Jennifer's hinting at was choice, giving them the idea of choice, that they're kind of in charge, even if they're kind of not in charge. You know what I mean? That this is the task that we need to get done. However you want to complete that task is up to you. Or this is how the task is normally done, but here's another way. You can choose whatever way works best for you. That kind of thing, right? So it's structured and they know what the task is. It's oriented, but you're not telling them this is how it has to be done, but it's still got that structure of getting the task done. Make sense? Cool. Dr. O'Keefe talks a lot about that. That's what his lifetime research is about, choice and how important that is in, mental health. And he loves OT and he's all about it because he loves the fact that we give patients choice and a holistic perspective in therapy. So, all right, so what can OT do? Go to table 10.1. It's on page 150 in your books. So these are some common OT intervention approaches for disruptive behaviors. Some of them kind of speak for themselves. Some of them are a little bit more, complex. One is the anger management, like what Lindsay talked about there. Developing alternative methods for managing emotions. You've mentioned like pinching the fingers, the counting. That's going to fall underneath that. Okay. Then you have cognitive orientation to daily occupational performance. This one, if you remember from a couple of chapters ago, we talked about it. I think it was with ADHD too. This is the 4-step strategy of goal, plan, do, and check. This is setting the goal, planning how to do it, actually doing it, and making sure that it was done, the way that it was supposed to be. Okay, checking, make sure. There's a few other ones there. We're going to do an activity, so I don't want to go over each one of them because I want you guys to think about how those can help, these different diagnoses. But overall, treatment interventions are going to be very specific to the patient. You're not really going to say, this is what I'm going to use for every patient that has ODD or antisocial personality or whichever. Um, you have to recognize, again, I think I've said it 100 times now, you have to recognize triggers because that's going to make all the difference in your treatment sessions. Let's talk for a second about medication. It's very, very, very complex. There is no specific medication for pyromania. I mean, it's just not how mental health works. It's used to help control different problem behaviors, but, most of the time medication is used secondary to other things like therapy. Medications can have a lot of different side effects like all the other ones we've talked about. So you don't want to increase their anxiety by accident and, have more or increase their stress level and have more disruptive behaviors. This last little picture here is kind of bringing home what I told you about. ODD is not caused by bad parenting or any of the other ones we talked about. It's not caused by bad parenting. Okay. All right. I got a couple videos. So Professor Hurt, if you want to, they're on the eLearn page. I know that they struggled being able to hear them last time. So I'm going to go ahead and play them, but they're on their eLearn page if you want to bring them up for Beckley. I'm going to mute ours so it won't be overlapping.